Right now, in joints throughout your body, a process is happening that has no pain receptors to warn you, no early symptoms to alert you, and no way for you to feel it occurring until the damage has already progressed far enough that the warning system finally activates, often years after the underlying degeneration actually began. This is cartilage degeneration, and understanding it completely, not just the symptoms everyone already knows about, but the actual cellular pathology, the specific causes, the diagnostic process, and the full range of treatment options from conservative to surgical is the difference between managing this condition reactively, after significant damage has occurred, and managing it proactively, with the kind of complete understanding that allows you to recognize early warning signs and make informed treatment decisions throughout the entire course of this condition. Today I am giving you the complete clinical picture of cartilage degeneration. What is actually happening at the tissue and cellular level, why it happens, what the genuine symptom progression looks like as the condition advances, how physicians actually diagnose and stage this condition, and the full spectrum of evidence-based treatment options available at every stage, from the earliest preventive interventions to the surgical procedures reserved for advanced disease. Before we begin, subscribe to this channel right now if you want this level of complete, clinically thorough health education delivered consistently. We build content specifically for people who want the full picture, not just the surface-level summary that most health content settles for. Hit subscribe. Let us start with the pathology, the actual biological process occurring within cartilage tissue as degeneration develops, because understanding this foundation is what makes every subsequent symptom, diagnostic finding, and treatment decision make complete sense. Articular cartilage, the smooth white tissue covering the ends of bones at every joint, is composed primarily of a specialized cell type called chondrocytes embedded within an extracellular matrix that these cells produce and maintain throughout life. This matrix consists primarily of tight to collagen, which provides the tensile strength and structural framework of the tissue, and proteoglycans, particularly aggrecan, which attract and hold water within the matrix, giving cartilage its characteristic ability to resist compressive load and distribute mechanical force across the joint surface. Critically, cartilage has no blood supply, no nerve supply, and no lymphatic drainage, meaning that chondrocytes must receive all nutrients and remove all waste products through diffusion through the matrix itself, a fundamentally limited system that becomes increasingly inadequate as cartilage thickness and the demands placed upon it change with age and use. In healthy cartilage, chondrocytes maintain a delicate balance between matrix synthesis and matrix degradation, continuously producing new collagen and proteoglycan to replace material that is naturally broken down through normal turnover. Cartilage degeneration begins when this balance shifts decisively toward degradation, a process driven by several converging mechanisms that research has identified over decades of cartilage biology research. Matrix metalloproteinases, a family of enzymes capable of breaking down collagen and proteoglycan, become upregulated and overactive, degrading matrix faster than chondrocytes can replace it. Inflammatory cytokines, particularly interleukin-1 beta and tumor necrosis factor alpha, produced both by chondrocytes themselves under mechanical or chemical stress and by the synovial membrane lining the joint, further suppress matrix synthesis while simultaneously promoting the matrix metalloproteinase activity that destroys existing tissue. And the chondrocytes themselves undergo a phenotypic shift, in some cases beginning to produce type 1 collagen, the kind found in scar tissue and skin, rather than the type 2 collagen that gives healthy cartilage its specific mechanical properties, producing repair tissue that is structurally inferior to the original cartilage it replaces. This degenerative process produces a sequence of microscopic and then macroscopic changes that pathologists and researchers have characterized in detail. The earliest changes involve fibrillation, a roughening and splitting of the normally smooth cartilage surface, visible under magnification before any change would be detectable on standard clinical imaging. As degeneration progresses, these surface irregularities deepen into clefts and fissures extending into the deeper layers of the cartilage matrix, and the overall thickness of the cartilage layer begins to decrease as the rate of breakdown exceeds the rate of repair. In advanced degeneration, cartilage loss can progress to full-thickness defects, areas where the cartilage has worn away completely, exposing the underlying subchondral bone directly to the mechanical forces and frictional contact that the cartilage was originally protecting it from. The biomechanical and load distribution dimension of cartilage health deserves additional depth beyond this initial pathology overview, because understanding precisely how mechanical force translates into cellular signaling within chondrocytes provides important context for why exercise and weight management interventions work at a mechanistic level rather than simply through general health benefit. Chondrocytes are mechanosensitive cells, meaning they possess specific molecular machinery, including integrin receptors and ion channels responsive to mechanical deformation, that converts physical loading of the cartilage matrix into intracellular biochemical signals affecting gene expression and protein synthesis. Critically, this mechanosensitive response follows what researchers describe as a biphasic or dose-dependent relationship: moderate physiological loading, within the range that healthy joint use and appropriate exercise provide, stimulates anabolic gene expression and matrix synthesis, essentially signaling to chondrocytes that the tissue is being appropriately used and should be maintained or even reinforced. However, loading that exceeds this physiological range, whether through acute excessive force or chronic overload from factors including excess body weight or joint malalignment, shifts chondrocyte signaling toward the catabolic, matrix-degrading pathways we described above, with research specifically identifying that excessive mechanical stress activates the same NF-κB inflammatory signaling pathway we have discussed extensively throughout this arthritis series, demonstrating a direct mechanistic link between mechanical overload and the inflammatory cascade that drives degeneration. This biphasic relationship explains why both complete joint immobilization, which removes even the physiological loading chondrocytes require to maintain healthy matrix turnover, and excessive joint loading, which pushes chondrocyte signaling into the catabolic range, can both contribute to cartilage degeneration through opposite mechanisms, while moderate, appropriately dosed exercise occupies the genuinely therapeutic window that supports rather than undermines cartilage health. The causes of cartilage degeneration fall into several distinct categories, and understanding which category or combination of categories applies to your specific situation is essential for both treatment planning and realistic expectation setting about disease trajectory. Mechanical overload represents the most extensively studied cause of cartilage degeneration, encompassing both acute traumatic injury, such as a significant joint injury, ligament tear, or fracture that damages cartilage directly or alters joint mechanics in ways that produce chronic abnormal loading afterward, and chronic cumulative overload from factors including excess body weight, occupational repetitive loading, and joint malalignment, where the mechanical forces transmitted through the joint during normal activity exceed what the cartilage's capacity for ongoing repair can sustain over years to decades of use. Age-related changes represent a second major causal category, operating partially independent of mechanical loading, though the two frequently interact and compound each other. Chondrocyte function declines with age through several documented mechanisms, including reduced responsiveness to the growth factors that stimulate matrix synthesis, increased cellular senescence, a state in which cells remain metabolically active but no longer divide or function optimally, and accumulated oxidative damage to cellular components including mitochondria, progressively reducing the cell's capacity for the energy-intensive process of continuous matrix production and repair that healthy cartilage maintenance requires. Genetic factors represent a third significant causal category, with research having identified specific gene variants affecting collagen structure, including variants in the gene encoding tight to collagen itself, that are associated with increased cartilage degeneration risk, alongside broader heritability studies indicating that genetic factors account for a substantial proportion, frequently estimated between 40 and 65% depending on the specific joint and population study, of the variation in who develops significant cartilage degeneration, independent of mechanical and lifestyle factors. Inflammatory and metabolic conditions represent a fourth causal category, including autoimmune conditions like rheumatoid arthritis, where the immune system's inappropriate activation against joint tissue produces direct cartilage damage through sustained inflammatory cytokine exposure, and metabolic conditions, including obesity, which contributes to cartilage degeneration through both the direct mechanical overload of excess body weight and through the independent inflammatory effects of adipose tissue-derived cytokines that we have discussed extensively in previous videos on this channel, demonstrating that metabolic disease can drive cartilage degeneration through pathways entirely separate from simple mechanical loading. Before we continue to symptoms, diagnosis, and treatment, here is your pause. Based on what we have covered about the causes of cartilage degeneration, which category do you think applies most to your own situation? If you are experiencing this condition, mechanical overload from injury or repetitive use, age-related cellular decline, genetic predisposition, or an inflammatory or metabolic contributor. Drop a comment below right now and tell us. Understanding which causal category is most relevant to your situation genuinely shapes which treatment approaches are likely to be most beneficial. And I want to understand the distribution of causes within this community. Now let us turn to symptoms and specifically to the critical clinical reality. We open this video with cartilage itself has no nerve supply, meaning that cartilage degeneration in its earliest stages is entirely silent, producing no pain, no symptoms, and no subjective indication that the process has begun. This is one of the most clinically important facts about this condition, because it means that by the time symptoms do emerge, the degenerative process has typically already been underway for a significant period. And the symptoms that eventually develop are produced not by the cartilage damage itself, but by the secondary structures and processes that the cartilage loss sets into motion. The synovial membrane's role in this process deserves more complete treatment, because increasingly sophisticated research has established that synovial inflammation, or synovitis, functions as both a consequence and an independent driver of cartilage degeneration, creating a self-perpetuating cycle that has significant implications for treatment timing and approach. When cartilage matrix breaks down through any of the mechanisms we have described, the resulting breakdown products, including fragments of degraded collagen and proteoglycan, are recognized by the synovial membrane's resident macrophages as damage signals, triggering an inflammatory response that produces the cytokines, including interleukin-1 beta and tumor necrosis factor alpha we described in the pathology section. These cytokines then diffuse back into the cartilage matrix, further suppressing chondrocyte matrix synthesis and promoting additional matrix metalloproteinase activity, creating a self-reinforcing cycle in which initial cartilage damage triggers synovial inflammation, which then accelerates further cartilage damage, independent of whatever initial mechanical or other cause began the process. This self-perpetuating cycle has an important clinical implication, because synovitis can independently drive continued cartilage degeneration, even after an initial inciting cause, such as an acute injury, has resolved, addressing the inflammatory component of cartilage degeneration through anti-inflammatory dietary, supplementation, and pharmacological approaches is not simply about managing symptoms but about potentially interrupting this self-perpetuating degenerative cycle at the synovial inflammation stage, providing a genuine disease-modifying rationale for anti-inflammatory intervention that extends beyond pure symptom management. The earliest symptom most patients experience is mild, intermittent joint pain, typically activity-related, initially meaning it occurs during or after specific movements or loading patterns and resolves with rest, reflecting the point at which cartilage loss has progressed enough that the subchondral bone beneath it, which does have nerve supply, begins experiencing mechanical stress it was not designed to bear directly, or at which the synovial membrane has become reactively inflamed in response to the cartilage breakdown products and inflammatory mediators we described, producing the synovitis we have discussed extensively in previous videos as a genuine pain generator independent of cartilage structure itself. As degeneration progresses, the symptom pattern typically evolves to include the morning stiffness we have detailed in previous videos, reflecting the circadian inflammatory pattern and overnight fluid redistribution within an increasingly compromised joint, crepitus, the grinding or crackling sensation produced as the roughened, fibrillate cartilage surfaces we described move against each other or against exposed bone in more advanced cases, and progressive range of motion limitation as osteophytes capsular changes, and pain-related movement inhibition combine to restrict the joint's full mechanical capacity. In advanced cartilage degeneration, with significant or complete cartilage loss in affected areas, symptoms typically include pain at rest and during the night, reflecting both the more severe synovitis that accompanies advanced disease and the direct bone-on-bone contact and subchondral bone changes, including the bone marrow lesions visible on advanced imaging, that occur once cartilage no longer provides any protective buffer between articulating bone surfaces, along with significant functional limitation affecting walking distance, stair navigation, and basic activities of daily living that we have discussed extensively throughout this arthritis series. The role of subchondral bone in cartilage degeneration represents another dimension of this condition's pathology that pure focus on cartilage tissue itself can obscure. The subchondral bone, the layer of bone directly beneath the cartilage, is not a passive structural support but an actively remodeling tissue that communicates bidirectionally with the overlying cartilage through both mechanical and biochemical signaling pathways. As cartilage degenerates and thins, the altered mechanical loading transmitted to the subchondral bone triggers compensatory remodeling, producing the subchondral sclerosis, increased bone density, that we will reference in our discussion of imaging findings, alongside the formation of subchondral bone cysts in some cases. Fluid-filled spaces that develop within the bone in response to the altered mechanical and biochemical environment. This subchondral bone remodeling is increasingly recognized not simply as a downstream consequence of cartilage loss, but as an active contributor to ongoing joint pathology. The diagnostic process for cartilage degeneration begins with clinical history and physical examination, where a physician assesses the specific pattern of symptoms we have described, including their relationship to activity, their duration, their distribution across one or multiple joints, and accompanying signs including swelling, warmth, and the specific patterns of tenderness on palpation that we have detailed in previous videos as having diagnostic significance for identifying which specific structures within and around the joint are contributing to the symptom picture. Standard weight-bearing X-ray imaging remains the primary initial imaging modality for assessing cartilage degeneration, though with an important caveat that deserves explicit explanation. X-rays do not directly visualize cartilage itself, since cartilage does not contain the calcium that produces contrast on standard radiographic imaging. Instead, X-rays assess cartilage loss indirectly, through measurement of the joint space, the gap between the ends of the articulating bones that is normally maintained by the thickness of the cartilage layer covering each bone surface. Progressive narrowing of this joint space on sequential X-rays provides indirect but clinically reliable evidence of progressive cartilage loss, and this joint space narrowing, combined with the presence of osteophytes, subchondral sclerosis, and cysts that we have described, forms the basis of the Kellgren-Lawrence grading system used to stage the severity of degeneration from grade 1 through grade 4. Magnetic resonance imaging provides substantially more detail, direct visualization of cartilage tissue itself, capable of detecting the early fibrillation and surface irregularities we described well before they would produce measurable joint space narrowing on X-ray, along with detecting associated findings including bone marrow lesions, meniscal pathology in the knee, and synovitis severity, that collectively provide a more complete picture of the structural and inflammatory status of the joint than X-ray alone can offer. MRI is not typically required for routine diagnosis and management of straightforward cartilage degeneration cases, where clinical history, examination, and X-ray findings are usually sufficient, but becomes clinically valuable when the diagnosis is uncertain, when symptoms are disproportionate to X-ray findings in ways that suggest additional pathology, or when detailed surgical planning requires the more precise anatomical information MRI provides. The clinical and research distinction between cartilage degeneration as it occurs in osteoarthritis versus the cartilage damage that occurs in inflammatory arthritis conditions like rheumatoid arthritis deserves brief but important clarification, because while both conditions ultimately produce cartilage loss, the underlying biology and treatment implications differ significantly. In osteoarthritis, the degenerative process we have described throughout this video, while it does involve secondary synovial inflammation as we detail, is fundamentally driven by the mechanical, age-related, and metabolic factors operating primarily at the level of individual joints affected by these factors. In rheumatoid arthritis, by contrast, the primary driver is a systemic autoimmune process in which the immune system inappropriately targets joint tissue throughout the body, with the resulting sustained severe synovial inflammation and producing cartilage destruction as a consequence of this autoimmune attack rather than as the primary initiating pathology. This distinction matters clinically because rheumatoid arthritis requires disease-modifying antirheumatic drug therapy specifically targeting the underlying autoimmune process, a treatment category fundamentally different from the comprehensive conservative management approach that forms the foundation of osteoarthritis treatment. Even though both conditions share the cartilage degeneration endpoint we have detailed, and both can benefit from many of the same supportive interventions, including appropriate exercise and anti-inflammatory nutritional approaches, alongside their condition-specific primary treatments. Now let us turn to the complete spectrum of treatment, organized from the earliest, most conservative interventions through the most advanced surgical options. Because cartilage degeneration management genuinely spans this entire range, depending on disease severity, symptom burden, and individual patient factors. The foundational, evidence-based conservative management approach, appropriate at every stage of cartilage degeneration from the earliest detectable changes through moderate disease, encompasses the comprehensive program detailed extensively throughout this entire channel, structured exercise programs targeting the specific muscle groups that protect and offload the affected joint. Weight management addressing the direct mechanical loading relationship we described in the causes section. Anti-inflammatory dietary modification addressing the inflammatory cytokine contribution to ongoing matrix degradation, and targeted nutritional supplementation, including the vitamin D, omega-3 fatty acid, and curcumin protocols we have detailed in previous videos that address specific biochemical contributors to the degenerative process at the cellular level we described in the pathology section. Pharmacological management, appropriate when conservative lifestyle interventions alone provide insufficient symptom control, includes the topical and oral anti-inflammatory medications we have detailed extensively in previous videos, used specifically to manage the synovitis and inflammatory pain component of the condition rather than to directly address cartilage structure. Since no currently available pharmaceutical agent has been definitively proven to reverse or meaningfully slow structural cartilage loss itself, a clinically important distinction that every patient managing this condition should understand clearly when evaluating any treatment, conventional or alternative, that claims structural cartilage benefit. Injection-based treatments occupy an intermediate position in the treatment spectrum, including corticosteroid injections, which we have detailed previously as providing effective but temporary anti-inflammatory and pain relief without structural benefit. Hyaluronic acid injections, which aim to supplement the joint's natural lubricating fluid and have shown modest, variable benefit in research with effects that appear most consistent in earlier stage disease. And platelet-rich plasma injections, an area of ongoing research interest where the patient's own concentrated platelets, containing growth factors potentially relevant to tissue repair, are injected into the affected joint, with current evidence suggesting modest benefit for some patients though significant variability in technique, concentration, and reported outcomes across different studies that makes this an area where the evidence base, while promising, remains less mature than the conservative interventions we detailed earlier. For advanced cartilage degeneration that has progressed despite comprehensive conservative and intermediate treatment, surgical options become relevant, ranging from arthroscopic procedures addressing specific mechanical contributors like loose cartilage fragments or meniscal tears that may be exacerbating symptoms, through cartilage restoration procedures including microfracture and osteochondral grafting, which attempt to stimulate or directly replace damaged cartilage in younger patients with more localized defects, through to joint replacement surgery, which remains the definitive treatment for end-stage cartilage degeneration, where the joint surface has been comprehensively destroyed and conservative and intermediate measures no longer provide adequate function or pain control. The emerging treatment frontier, which we covered in detail in our cartilage breakthrough video earlier in this series, includes the cellular senescence targeting compounds and stem cell-based regenerative approaches currently progressing through clinical trials, representing genuinely novel therapeutic strategies that work through fundamentally different mechanisms than anything we have described in the conventional treatment spectrum, potentially offering the first treatments capable of meaningfully reversing rather than simply managing or slowing cartilage degeneration, though these approaches remain in active clinical development rather than standard, widely available clinical practice at this time. This complete picture of cartilage degeneration, from the silent cellular pathology that begins the process, through the diverse causal pathways that initiate it, through the symptom progression that eventually brings it to clinical attention, through the diagnostic process that characterizes its severity, to the full spectrum of treatment from foundational conservative management through emerging regenerative approaches, represents the comprehensive clinical understanding that this condition genuinely deserves, rather than the fragmented, symptom-focused picture that most patients receive in the course of routine clinical care focused primarily on the immediate management decision at hand. Understanding this complete picture does not change what is happening in your joints right now, but it fundamentally changes how effectively you can participate in your own care. Recognize the early warning signs we have described, understand why each component of the comprehensive management approach this channel has detailed actually works at the cellular and tissue level, and make informed decisions as your condition, if you are managing this, progresses through whatever stages it may reach over the years ahead. If this video gave you the complete, clinically thorough understanding of cartilage degeneration that you have been searching for, please support this channel. Hit the like button right now. Subscribe if you have not already, because we are committed to providing exactly this level of complete clinical depth on every topic this channel covers. Share this video with anyone managing joint health who deserves the complete picture rather than a fragmented summary. And leave a comment below. Tell us which section of this video, the pathology, the causes, the symptoms, the diagnosis, or the treatment options was most valuable for your own understanding, and what you would like us to explore in greater depth in a future video. We read every comment. Thank you so much for watching. See you in the next one.